Hello everyone, I'm Dr. Muhammad Ilyas, and today in this session I'll be talking about lower limb deformity correction using intramedullary interlocking nail and percutaneous osteotomy guided by polar screw or a blocking screw. We all know that as long as you follow the basic principles of deformity correction, there are various ways of managing long bone deformities. You can either do them in an acute way or gradually correct them. You can use an Ilyas frame or lateral spatial frame. You can do an internal fixation after an osteotomy and either use a plate or an intramedullary nail. It's totally up to you as long as you're following the principles of deformity correction. So you all know, I'm sure, that the mechanics of the polar screws. So in trauma settings, whenever there is a fracture in the metaphyseal area or a metadiaphyseal area, and you don't want to create a deformity after your fixation, so you use polar screws in the metaphyseal area to correctly direct your intramedullary nail. So using the similar principles, we correct these complex, usually multi-apical lower limb deformities by guiding them in a correct trajectory in the metaphyseal area, doing an osteotomy, and then advancing the nail in the diaphyseal area, and then correcting the deformity. So in this method, we do make an intrapatellar incision, and using a medial parapatellar approach, we pass a retrograde intramedullary nail into the femur and an antegrade intramedullary nail into the tibia after doing percutaneous osteotomies in the marked sites and direct them in the metaphyseal area using polar screws. So I'm going to show you the technique one step the way so that you can get an understanding. So in this case, you see an x-ray, obviously as you can see it's a valgus deformity. It is very important that you get a true AP view because most of these patients, they have got torsional deformities as well. So it's very important that you get a true AP view of the knee by looking at the patella at the center of the knee joint, obviously if the patella is not dislocated, and then marking a imaginary line which is at 81 degrees of the reference lateral distal femoral angle, and then using these polar screws we're gonna guide our intramedullary nail in the metaphyseal area, then doing a percutaneous osteotomy just proximal to the place where this line hits the cortex, and then do joysticking, and then introducing the reamer, first the reamer into the diaphyseal area, realigning the bone, and then putting in an intramedullary interlocking nail. As this is an example case, an 81-degree line is drawn on an x-ray, and this is the placement of the polar screws. You see, if in a valgus deformity, the tendency of the nail in the metaphyseal area is to go in this direction, make this path in the direction in the metaphyseal area. We want our nail to go exactly at the 81-degree line, so we pass a polar screw here, and in the metaphyseal area after the osteotomy, once we're going to do this joysticking maneuver in the metaphyseal area, the nail will try to toggle and move this way. So to avoid this, we put a medial screw a little distal, and then as you can see, it's a procurvatum deformity in the sagittal plane as well. So the nail is going to try and go this way and hit the posterior cortex. We don't want that. So to avoid that, we're going to pass a posterior polar screw in the lateral view as well. Same goes with the tibia. We're going to draw an imaginary 87 degrees medial proximal tibial angle here as well, and then we're going to put a polar screw here so that the nail doesn't go in this direction, and then a proximal medial screw, and then do an osteotomy and then advance the nail into the diaphyseal area. So this is our planning. So this is a C-arm image of where we're gonna be putting our first polar screw. The knee has to be a true AP view with the patella centered. And once we have put our polar screw both in the AP and the lateral plane, then we're going to introduce the reamer. And then once this is the most important step actually. Once you're going to pass a reamer, you're going to take an image with your C-arm, and then you're going to ask your assistant to draw a reference line, the angle that this reamer is making with the joint orientation line of the distal femur, and it has to be 81 degrees. If it's unacceptable, if it's too low or too high, you're going to remove the screw and re-enter your reamer after passing another screw in an appropriate direction. This is the most important step. And if you have passed your reamer in the correct alignment, then all you need to do is do your osteotomy, advance the nail into the diaphysis. As you can see here, distal polar screw another pass to avoid that toggling of the reamer. And then in the diaphyseal area, it's quite simple. Wherever this reamer hits the cortex, you do an osteotomy. It's a diaphyseal area. There is no other place for this reamer to go. So it's going to go in only in one trajectory. See, another osteotomy done. How many osteotomies you need, you can do it. And then you pass your reamer, your nail, and do locking. Another very important thing. These patients usually with multi-apical or severe deformities, they have torsional components as well. So once you do an osteotomy, you realign before you're doing your locking, you realign your leg. And once the alignment, once hip, knee, and tip and ankle are in the same plane, and you're sure that you've correct the torsional components, then you do your locking. So with this technique, not only can you correct your oblique plane, your biplanar deformities, or your multi-apical deformities, you can correct the torsional components that come with these complex deformities as well. And since these are percutaneous osteotomies, you don't disrupt the periosteum, the healing is very quick. So you see here, same with the tibia, as you can see here. Again, once you have, after you're putting your blocking screws, you're gonna introduce your reamer. Then your assistant is gonna measure the medial proximal tibial angle for you. It has to be 87 degrees. Then you put your second polar screw and then do your osteotomy. Introduce your nail. How many osteotomies are needed is no problem. You can do them, and then do your locking. You see, in this case, now I'm going to show you a couple of cases as an example. This patient has torsional deformity as well. As you can see here, knees in AP, there is rotation in the femur. And this patient has varus deformity on the left side, a little bit of valgus here as well. And in the tibia, the deformities are not proximal, they are distal. So you're going to be putting your polar screws in the distal metaphyseal area. So again, two osteotomies needed in the femur on the left side, one in the tibia, and you get your desired correction. LDFA of 81 degrees and MPT of 91 degrees achieved here. As you can see here, you can see solid fusion at all the osteotomy sites. And here you can see post-operatively, the leg is very nice and aligned. Another case on the right side, there is LDFA of 47 degrees, and on the left side it's 54 degrees, and both of these patients have recurvatum in the sagittal plane, procurvatum in the sagittal plane as well. Again, on the left side, 82 degrees of LDFA achieved after doing 3 osteotomies here, the femur, and a little bit overcorrected here, 85 degrees of LDFA on the right side. As you can see, alignment has been achieved. So this was a brief overview about my technique of correcting these complex deformities. And as you can see, this is a very low-tech way of dealing with very complex deformities. All you need is an intramedullary nail, a few screws, and a C-arm. That's it. So using these techniques, you can correct all these deformities safely in a very good way and achieve some good results. Thank you very much.